Live. Good morning, everyone, from the new monthly appointment of Journal of Cardiac Surgery, our live webinar that we call Live Talks with the authors. I'm Gianluca Torregrossa from Lankenau Heart Institute, and today I'm here with Irbaz Hamed from Yale University and Thomas Salerno, editor-in-chief of Journal of Cardiac Surgery. Every month we have an appointment where we select the best article of the issue published from Journal of Cardiac Surgery. And on a Saturday morning, in front of a cup of coffee, we have a conversation with the expert of the field. And we just wanted to implement culture and knowledge about a specific topic. Please feel free, whatever platform you're using, to watch this live, to ask some questions or interact with us. We will see all of your comments and tell us where you're from or where you're following us from. Today, we have the pleasure to discuss a paper from Sophia Alexis as a first author. So, Sophia is a PGY4 from the I6 CT program at Mount Sinai Hospital, and she's also the hands and the brain behind the Twitter account of Journal of Cardiac Surgery. The paper is titled Anatomic Classification of Mitral Annular Calcification for Surgical and Transcatheter Mitral Valve Replacement. The senior author is Gilbert Tang, Surgical Director of the Structural Heart Program at Mount Sinai Health System, that is going to join us in a few minutes. And we will discuss the paper with Kendra Grab, Surgical Director of the Structural Heart and Valve Center at Emory University in Atlanta, and with Mayra Guerriero, interventional cardiologist, well known with a special interest in structural heart intervention from Mayo. Sophia, the floor is yours. Please give us a perspective about and show and a little presentation about the paper, and we are here to start the discussion to follow.
Sure. Thank you so much, Dr. Torregrossa and Dr. Salerno and Dr. Hamed, for the opportunity to present this paper. And it's an honor to be, in the presence of Dr. Grubb and Dr. Guerrero, experts in the field, to discuss this topic. So this paper is entitled Anatomic Classification of Mitral Annular Calcification for Surgical and Transcatheter Mitral Valve Replacement. We came upon this study topic because we found a lot of patients in our mitral reference center who were coming in with MAC and mitral disease and significant comorbidities. In the past, we had limited options for their treatment. It was either surgical mitral valve repair replacement, which comes with the issue of resect that calcium, which has its own morbidity, medical therapy, or valvuloplasty. But now we have this new technology with transcatheter mitral valve replacement. And so we wanted to see, how can we analyze patients' anatomy and how can we find what would be the best fit for their treatment? And not only do we have transcatheter mitral valve replacement now, we have the option of placing it percutaneously or through a hybrid transatrial approach, which would involve surgery. So we joined Columbia University and their expert structural team there, and we were able to gather 82 patients from our two centers to evaluate their MAC from September 2015 to July 2019. And as you can see with their patient characteristics, this was a group that had multiple comorbid conditions. So over 60% had coronary disease, over a third were diabetic and had chronic kidney disease. We had a good amount who had previous radiation, hostile chest, and their STS scores were quite elevated, average of 9.4%. There was a mix of pathologies of the valve in terms of stenosis and regurgitation, and you could see the breakdown at the bottom of the table there. So we started off by looking at these 82 patients and inputting their data into 3Mencio. We had a bunch of metrics that we took, some of which you can see here, such as the anterior posterior diameter of the mitral valve, their intercommissural distance, which helped us look at how eccentric the valve was, how elliptical, because we were doing a placement of a circular valve for our virtual assessment. We looked at aortomitral angle and, very importantly, neo-LVOT. We used a cutoff of 170 millimeters squared based on some previous papers. So any number less than that, we considered obstructive. We looked at maximum calcium width and height, amongst other things. And then we looked at the amount of calcium around the annulus, breaking up patients into partial MAC or horseshoe or greater MAC, whether the number was greater than 270 degrees or less. We created a MAC treatment algorithm based on these patients with type 1 MAC, which we were calling partial MAC, and type 2A and 2B MAC. So type 2 MAC is horseshoe or greater, so greater than 270 degrees of the annulus had calcium burden. And we decided to break 2 into 2A and 2B because we found that whether the patient had predicted LVOT obstruction was very important. So low-risk patients we called 2A, and high-risk patients we called 2B. So as you can see in our algorithm, our first step was to really determine surgical candidacy. Was this someone who would be able to tolerate the stress of an operation and the morbidity that comes with it? Next, we looked at the anatomic feasibility, and we kind of made this algorithm to decide whether it'd be best for them to get percutaneous treatment, hybrid treatment, surgical treatment, or medical therapy if they didn't have anatomic feasibility and if they were not an operative candidate. So what we found is that taking all 82 patients and placing a SAPIEN 3 valve with 30% atrial, 70% ventricular position, about almost 60% of the patients had predicted LVOT obstruction. Out of the patients, which were half that underwent intervention, 7 actually did have LVOTO by gradient, and 5 of these 7 were predicted. So had we had the anatomic classification before that, we could have possibly been able to avoid those. In terms of type 1 versus type 2 breakdown in those who underwent intervention, half had partial MAC and half had that horseshoe greater than 270 degrees or greater MAC. We did look at STS, predicted risk of mortality, and found that even though the numbers were very high for this patient population, when we asked surgeons what they felt that the patient's risk was, looking at other things that aren't necessarily in the STS calculation, they felt the patients were even higher than these numbers. So 61% of the non-intervened patients were actually extreme risk based on one of 4 categories. So the categories for the non-intervened patients were either because they had anatomic issues such as hostile mediastinum, LVOT obstruction, a tall anterior mitral leaflet. Maybe they had clinical considerations, which is why they weren't able to be intervened on. They came in acute heart failure and needed optimization, or they had acute liver failure or recent stroke, a combination thereof of anatomic or clinical prohibitive factors, or patient or provider preference, where it was felt that the patients didn't necessarily need intervention at this point, but maybe in the future they could. So the actual procedure for the transcatheter mitral by the VARC definition was very successful. 88.5% of patients had a successful procedure. But when we looked at follow-up, which was at an average of about 30 months, all of our percutaneous patients, it was an N of 6, had expired. Now, there are a couple of reasons for that. We think that these are patients that were such high risk that they didn't undergo a hybrid transatrial approach or a surgical approach because they wouldn't be able to tolerate surgery. And, it makes sense that it was significantly higher than those who underwent surgery or the hybrid approach or the ones that we just decided, not to operate on. The transatrial patients, as I mentioned, had a lower STS score. And the benefit of the transatrial TMVR approach, where you want to try and minimize your pump time and where maybe you can't get all the annular sutures in that you need to, just enough to anchor the transcatheter valve, is you also have the ability to address the patient's other pathologies. So 60%, quite a big amount, had additional procedures like CABG, tricuspid valve repair, aortic valve replacement, and septal myectomy. And on the right, you can see the breakdown of the patients and the amount of calcium burden they have and what procedures they underwent. So in conclusion, we sought to find the best way to classify these patients and quantify their MAC to determine the optimal treatment for them with a bespoke strategy that took into consideration what their neo-LVOT would be with virtual valve placement and their calcium burden. And we hope that this treatment algorithm will help practitioners in the future with the management of this complex disease.
Thank you so much.
Thank you very much, Dr. Alexis. That was a very comprehensive presentation and a very well designed and performed study. And you excellently summarized everything. I will give the floor to Dr. Tang, who joined us, and he is the senior author of this paper and also the director of structural heart at Mount Sinai. Dr. Tang, what are your thoughts on the value of this paper in the current structural heart field, and would you see the implications of this study, and what are the future directions for people that are carving their trade in this field?
Well, thank you very much for the introduction. I apologize for joining late. I had some technical connection issues. So, but first of all, thank you for the invitation to discuss this paper. And obviously, Sophia was the one who spearheaded this project. And actually, we also consulted a little bit with Myra as well, because of a recent publication of the MAC score, which is quite timely in terms of getting more understanding of this complex disease. What we try to accomplish with the two centers, and hopefully Isaac can join as well, is to look at the CT anatomy of patients who all comers come for our valve clinic to evaluate for intervention, whether it's surgical or transcatheter. Because the thing is that we only see the tip of the iceberg where we have patients intervene, including Myra's registry. I'm sure Kendra has seen many of these patients as well, and maybe Gianluca and Dr. Salerno. But we don't know how to kind of present a more organized fashion to treat these patients. And this is, I think, in my mind, the first time we really try to understand, well, if we have a bucket of patients evaluated for intervention for MAC and mitral disease, what happened to them, and how did they do, and how many of them actually potentially truly anatomically eligible, at least for the balloon expandable valve. So that's kind of what we found and what we did. The classification, as you know, now may be applicable even for the devices that are designed for native MAC and mitral disease, not a balloon expandable platform, so such as the Tandem valve and now with the Intrepid evaluation. The reason being we did not look at those here is that they each have their own specific sizing algorithm, which actually is almost proprietary. So we could not say which patient might have been eligible for those. But as you can see, most of these patients have smaller anatomy, and Myra and Kendra can expand on those further. And they are usually not amenable to these larger self-expanding devices due to LVOT obstruction or just sizing constraint. One thing we did not look at here, of course, is adjunctive techniques to facilitate anatomic inclusion in terms of LVOT obstruction. And Myra and Kendra has previously published and presented on this. So this is included septal alveolar ablation. And of course, the lampoon technique, because at this time during the study period, these are still relatively early experience. We haven't quite figured out how to manage these patients in terms of LVOT management, I would say. And at the same time, not everyone has septal anatomy amenable to this approach. So I think that at least in our mind, what we'd like to do is to present a very, I would say, a dumbed down, simple approach in terms of classification. So once you have those, can then look into these treatment options. Is it going to be surgery because there's not enough MAC to anchor, or can it be a dedicated TMVR device? Is that going to be LVOT obstruction? However way you measure it, whether it's by multi-phase measurement or dedicated way, or even skirt neo LVOT. Now there's some concepts on that using, for example, with the lampoon technique. You can do those sophisticated measurements, but at least you can start to categorize them in this more simplified manner, and then do a deeper dive like what Myra has proposed with the MAC score and other means.
Thank you. Thank you very much, Dr. Tang. That was very nice summary of the paper and what it means for everyone. Dr. Guerrero, you've done a lot of work in this. We were reading your paper on JACS, and you there was a mitral trial that you did. What are your thoughts on the strategy that Dr. Alexis, Dr. Tang, and their team proposed to classify mitral annular calcification, and what is the approach at Mayo Clinic for such patients? How do you go about it?
Thank you very much. Well, first of all, congratulations. It's a very nice idea to simplify the process. I think it can help a lot of people, categorize these patients in a simple category. I'm just worried that we might be too simple. So just for the audience, this is a very high-risk patient population. So I think it's a good strategy as initial classification. And once you have them in your 2A or 2B, perhaps then add a little bit of refinement in patient selection. Before I go to the second question, I just wanted to mention, as I was listening to your presentation and looking at the numbers, it's very interesting to see how the population that you're presenting is the same population everywhere. So there's so much to learn, but at least we're learning the type of population that we're dealing with. About 70% of your patients were women, which is kind of the same. Whatever you look at, whatever the registries are, is about the same. And, high risk, many of them, about 50% in different registries had either history of aortic stenosis or prior AVR, or a combination of either AVR or TAVR or something. And also a large proportion have high risk of LVOT obstruction. So it's very consistent, the definition of the population. The one thing that got my attention was the higher mortality in patients who were treated with transeptal approach. And that's where I want to comment that maybe it's good to be simple at the beginning as initial screening, but I think we may have to go a little bit deeper into the patient selection. And of course, this, I'm sure, probably included early experience. So like many of us in many of the registries, the outcomes were not that great at the beginning. So I wondered if the patients who were treated with transeptal access were first of all higher risk, as you mentioned, with the STO score, maybe older, but also maybe patient selection could have played a role in terms of predicting anchoring or predicting LVOT obstruction or the strategies. And that's where I want to go into the predicting anchoring. So I'll tell you what we do at Mayo Clinic, because that was your question. And then I'll ask you, how do you decide, this question would be for Dr. Tang and Alexis, how do you decide once you are in the 2A, 2B category, how much of the horseshoe or how much calcium is going to be enough to predict good anchoring? Do you implement the use of the MAC score, or do you think this simple category? Have you done any testing? I wonder maybe this is enough if as long as you have that type of distribution of calcium that you're describing. I wonder if that's enough. Maybe a comparison of that versus the MAC score would be helpful. Last comment is the answer to your second question. What do we do at Mayo? I start with the MAC score. So I get the short axis view on CT. And then if the MAC score is 7 or greater, then I know I have options with transeptal approach. And then if the MAC score is 6 or less, then we start looking at other possibilities. Some of the new transcatheter mitral valve devices in their trials that are allowing some degree of MAC. So we explored other options like the TMVR in a different trial, or transatrial TMVR or medical treatment. But if the score is 7 or greater, they're candidates for transeptal valve in MAC. And then we assess the risk of LVOT obstruction. And if it's high, which is high in most patients, then we look at options to decrease that risk. We look at the septal anatomy, the thickness of the septum. If it's too thin, then we know that too thin, and that still needs to be defined, but let's say it's 1.2 centimeters or less. Then, maybe alcohol ablation may not be the best option. Then you start looking at maybe lampoon. But if the septum is thick and the coronary angiogram shows a good septal target, our initial approach is to proceed with alcohol ablation because it's a technique that we all are very familiar with. The outcomes with that technique, the contemporary outcomes are just getting better and better. They're not like the initial experience. And we get very reproducible results, remarkable, I should say. And if that's enough, then we can proceed with transeptal valve in MAC. And if that's not enough, then we add additional septal reduction treatment with radiofrequency. And also, we've been getting very good results with that. But it's not uncommon that some patients need the combination of all, and some patients, despite all those two, they still need Lampoon. So we had at least a couple of those. But the bottom line is that you get to the table and you're able to proceed with safe transeptal valve in MAC without having LVOT obstruction at the end. And that's what we do now. And all I can say is the outcomes into 2021 are much, much better than they were years ago with the combination of all of the above. We have seen patients who are not candidates for alcohol septal ablation due to septal thickness, as I mentioned, or lack of a good septal artery target, or sometimes the contrast, the echo contrast, go to an unwanted area, and you don't want to inject alcohol. So it's not clear, the same path will not work for all patients, but you can tweak and adjust according to the anatomy, and a combination of those three usually will lead you to a safe transeptal valve in MAC. So that's what we do. I'll stop talking, and then I'll ask you, what do you do once you get into that category of putting them in 1 versus 2A to B? What's your next step? How do you predict anchoring? Because you don't want to have an embolization or a valve emboli. So what do you do?
Well, thank you. I think it's really important to consider all those adjunctive techniques, and all of Dr. Tang comment on, our preferences at Sinai. In terms of surgical approach, we're really, have a preference for surgical mitral valve in the type 1, where we know we can take good annular bites and we won't have to worry so much about violation of bars of calcium. In terms of 2A and 2B, patients that have horseshoe or greater circumferential MAC, I think if they are operable, the hybrid approach is really great because it's less time on pump. You don't need as many sutures to anchor, and you can do like the surgical version of taking care of the anterior leaflet by just resecting it. So you can just get that out of the way to clear up the LVOT. If they're 2B, and they just have this, no matter what, their LVOT is going to be obstructed and they're inoperable, we prefer to have a medical treatment. If they're 2B and they're operable, again, we'll do the hybrid transatrial approach.
Yeah, I'll just add further, Myra, that obviously your MAC score was only recently published a year ago, so we don't have that at our disposal. Based on this experience, which, as you saw in the study period, was quite early, as you mentioned. So we were all learning at that time, and we contributed a couple of patients to your trial early on, and we also learned from some of those experiences. What we found was that, as you mentioned, based on our algorithm and organization, now, of course, we can refine, as you mentioned, using the MAC score to see if there will be sufficient anchoring based on the 1A. So 1 and 2A, 2B. So 1 clearly, as you mentioned, would not be feasible for percutaneous approach just because there's not sufficient MAC, and so we have to explore, either the surgical option or the dedicated transcatheter option, depending on the patient's operability. I think the message for our paper is really, are they operable? If they're inoperable at all, then you really just going to be looking at percutaneous option or medical therapy only. And to your point, really just, and then we have to look at the LVOT. I think from the audience standpoint, if you consider surgery on these patients and they are operable candidates, what we found at least, and I'm sure Kendra and Myra, you've seen that in your studies and your experience, that with the direct approach, you have a bit more laxity in optimizing the implant. What I mean is that, as you know, with the percutaneous approach, you have to oversize to avoid migration or embolization. With the transatrial approach, you have the little bit of luxury of adding felt to add a bulk against the paravalvular leg, and also sealing and anchoring against the native annulus. So we sometimes have not had to oversize too much. In fact, we may have true size, and we actually have the luxury of being in the operating room to add sutures to help secure the frame a little bit, so avoid any kind of migration. In fact, I'll tell you a story that we had a recent case. We did a direct approach. We put one layer of valve. It was slightly undersized, and when we actually were giving protamine, we had a migration. So we had to went back on bypass and actually put another layer of valve on a new valve and put a bunch of sutures on the atrial side to secure it, and it was perfect. And the patient was able to discharge from no issue. And thank goodness it happened in the operating room rather up in the intensive care unit, because she was actually decompensated. But we're also very aggressive doing surgery on patients, at least in our center, which have a lot of experience, obviously, in mitral valve surgery, Dr. Adams and the mitral team. So this lady that I mentioned just now was in her mid-80s, and I think most centers would have turned her down and consider transeptal TM rehab. Not that is not a good option. In fact, probably in centers like yourself and Emory and Mayo with adjunctive techniques would certainly be able to offer that option to the patient. And this patient had actually circumferential MAC. So the MAC score was very high. But in our mind, at least in our experience, based on our outcomes, we feel that the patient was operable, and in fact, we also repaired tricuspid valve, which obviously percutaneous approaches cannot do it simultaneously, and would have to do it in a stage approach. We felt that we would be able to get these patients through. One final comment before getting back to Urbas is that we also do a lot of pre-op optimization on these patients. As you know, they have often severe pulmonary hypertension. They have other medical comorbidities like liver, renal disease. So we actually, if we're going to be doing a transatrial approach, we admit a few days before to optimize them medically so that their post, of course, are a bit more smoother. And of course, post-op management is just as important.
Thank you, Dr. Tang, Dr. Lexis, Dr. Guerrero. I will turn to Dr. Grubb. What are your thoughts on the conversation so far? What is your approach at Emory for MAC classification, and how do you approach these patients? But I will just make a quick note for our audience. If you have any questions, please feel free to drop them in the comments. We will try to raise as many of them as possible. Just keep them coming. Dr. Grubb.
Well, thank you for having me this morning, and Sophia and Gilbert, excellent work adding to our body of knowledge on this. Myra, thank you for all of your early work with this. I would say at Emory, we have a kind of a combination of everything that's been discussed. We have not strictly gone to a MAC score yet. We discuss it, but we're not routinely calculating it. It's still kind of a new thing, Myra, but I think it's extremely helpful. I think that kind of your algorithm is what we were doing, but without actually formalizing it. So Sophia, thank you for putting it out there in the literature for people to use. But risk stratification first, and then anatomy based on the CT scan and anatomical considerations of how much mitral annular calcification exists. Then the virtual valve to measure the neo-LVOT. And then we've actually added one other piece to it, which is what we call the Emory angle. And because when you come percutaneously, the valve doesn't necessarily sit coaxial in the annulus, if your canting angle is more than about 15 degrees, then you possibly miss the sealing zone with the skirt. So we've moved to measuring this angle ahead of time and then externalizing the wire directly through the chest wall in order to gain coaxiality. And then all of the other adjuncts that were already addressed, lampoon, adding a skirt that we have called a Schmoltra for the larger valves. And we're now even adding that for some of the valves that are smaller where we feel we need that extra bulk. So we're doing all of the things that are described. But compared to where we started to where we are now, this is an incredibly challenging patient population. And you're going to have to add all these adjuncts. And so for the audience, I actually want to take a little bit of a step back. Gilbert, you talk about this hybrid technique. I've heard your presentations, Isaac's, Yoshi's. We have some people that are truly experts with this hybrid procedure, but can you actually explain to us what it means so that everyone in the audience understands what the technique actually is?
Sure, and Myra can chime in too, since you were the PI for the mitral trial, and we did include some transatrial approach, and obviously we published together a technique with as well in JOCS on how that's done. So I think there are several different variations on the theme. But first of all, I think to your point is are there room to anchor some sutures at the annulus? I think that's the first question. And if there are, we would tend to do that. The second is, can we quote unquote circularize the annulus? What I mean is that, as we know, the mitral annulus is more D-shaped and not circular. And when you put a SAPIEN 3 valve in there, it's going to circularize the annulus. And you want to avoid paravalvular leak. So we would try to see if we can close the commissures medially and laterally if it's not calcified, to try to placate that area to circularize so that we can create a more optimal landing zone. The third thing is that we almost always add a Teflon felt strip, depending on the height of the valve and the size of the valve, so that you basically create a cushioning zone to minimize the gaps and creases against the calcified annulus, particularly in those that spiculated calcium that might stick out into the annular orifice that might cause paravalvular leak. I think that's very important, and we sometimes even double felt to add extra bulk to create the anchoring. And this is particularly important, at least in our mind, if you don't plan to oversize the valve too much for concern of potential AV groove disruption, which of course have not been reported in the percutaneous approach, but it may certainly be possible, especially given it's now an open chest situation. It might be different physiology. And then finally, remember, unlike the percutaneous approach, which is truly physiologic on a beating heart, we are deploying this valve directly in the arrested heart, which the left ventricle is completely flaccid. So we typically have two operators doing this procedure at the same time. So the first operator will directly use articulated forceps to optimally position the valve. We try to also align the commissures relative to the native commissures, kind of like what we do with a surgical mitral valve replacement in terms of optimizing the flow. And we typically, I know there's some conversation about using the wire or not using the wire. Not a stiff wire rather, but just a wire to straighten out the balloon. We have not done that. We actually cut those cones to make it a little stubby to avoid any LV perforation in the arrested heart. And we then, the second operator, then slowly inflate the valve against the anatomy, making a lot of time to adjust to optimize the deployment. A couple little tips and tricks. What we've done is obviously we try to resect the anterior leaflet to avoid alveolar obstruction whenever possible. However, you might need to leave a little remnant for those of us who are surgeons in the audience to put some sutures on the anterior side as possible. However, sometimes exposure can be very difficult, particularly if it's some reoperative situation with the patient had prior open heart surgery, or if the patient had a previous TAVR, right? So it's not that easy to expose it unless you perhaps do it from a right thoracotomy approach. To see this, and of course, one of our colleagues, Tom Wynn, had even done it in a robotic or minimum radius approach. What we also try to do in terms of commissural marking is that, remember, once you place the valve in the cross annulus, you don't see the commissural post anymore. So we use a marking pen to mark it on the felt where the commissures would have been seated. So when we inflate, we can try to optimize the alignment anatomically. Once it's inflated and anchored, of course, we do our saline test. That's a poor man's physiologic test to check for any paravalvular leak or transvalvular leak. And if it looks good, then we proceed to close. So the whole steps and process, I would say, is still around 15, 20 minutes. It's not like 5 minutes you put it in and you wrap up because there's still a lot of thought process involved. If we're not sure about how much volume to add or sizing, we might even actually use one of the Edwards balloon to balloon directly to kind of open up the MAC area to make it more compliant for the final valve deployment. And we use the Certitude system, which was designed for transapical or direct aortic or even carotid approach for this procedure instead of the Commander system, which is much longer and harder to manipulate in the operating room.
Gilbert, excellent presentation of the hybrid approach. Thanks so much, and thank you everyone for this conversation. Kendra, where do you think is the future of this hybrid approach? So this idea of taking, in this moment, a TAVI and then putting into preparing with some felt, as Gilbert described, with these precise techniques, taking your time, and then try to anchor in the appropriate position of the mitral annulus. Do you think that with the advent of new technologies, new platform, new devices designed for mitral valve, the hybrid will disappear, or do you think the hybrid will take a new role with new devices. So we will not deploy a sapien or a valve design for an aortic annulus, but instead we will try to apply in a rested heart a percutaneous valve design for mitral. Give us a little bit of read the future for us, please.
Well, I would predict that as we have designated mitral devices available, you will see us transition to using those devices in the mitral position. Right now, this is what we have available for a patient population who doesn't have a lot of options. And so we're using the tools that we have, modifying those tools, and then trying to help patients who don't have a surgical alternative. As the percutaneous devices evolve, I think that it would be wise to start looking at these in this position. Gilbert alluded to it earlier. The mitral valve is not a circle, and we're putting a circular valve. So a D-shaped valve that fits the anatomy is going to be more of an anatomical solution and optimize the shape of the annulus. Gilbert mentioned before that risk of paravalvular leak by putting a circle in a D. Well, that could all go away with a properly designed anatomic mitral replacement. I think ultimately what you will see is that the percutaneous approaches will be more refined. A lot of what we're learning now is kind of the early stages. And so by adding really good preoperative planning, intraoperative modification, a lampoon that would mimic resection of the anterior leaflet or a portion of the anterior leaflet, externalizing wires to gain coaxiality. There are so many tricks that we're learning now that by the time a designated mitral platform is available, we'll be able to give patients a really good result.
Yeah, one thing I'll add further to Kendra is I remember the Emory Angle recently published, very nice actually. And we even think about using it for valve in valve as well, because recently we have a very difficult case in terms of crossing the septum to the prosthesis. But also, I think one of the nice things about the transatrial approach is that if the patients require concomitant cardiac procedures, as Sophia has mentioned in the series, and they're truly operable. What I mean is that maybe a 75-year-old on dialysis have MAC, but need the CABG or tricuspid repair or whatever it might be. This is a very nice approach to shorten the cross-clamp time and pump time to get the patient through, because as you know, some of these patients with MAC, as Myra and Kendra and you guys have seen, have their own quote-unquote protoplasm, right? They're not the healthiest patients out there. There's a reason why they have MAC. It's just that these patients now have MAC and mitral disease present quite advanced part of their cardiac progression of cardiac disease. So I think this is kind of a nice way to really get the patient out safely and be able to help them really with their quality of life, because I'm not sure the natural history of these patients with MAC and mitral disease. It's kind of like patients with, for example, secondary MR with heart failure. We're looking for like a long-term survival per se. I know Myra is doing the Mitral 2 trial, so it'll be interesting to see what the longer-term follow-up is, randomizing patients with percutaneous TMVR versus medical therapy. I mean, that's going to be the real question. Are we really truly helping these patients by treating the underlying mitral disease in the context of other comorbidities?
And Gilbert, you bring up a good point, because in your series, or maybe the question's better for Sophia, in your series, the actual medical arm did better. They did well. And I'm wondering if what you captured was acute on chronic presentations of diseases, something that's treatable acutely. You didn't operate on them initially, but their underlying MAC continued. Can you talk a little bit about who those patients were?
Sure. I think it's a little bit tricky because while the medical therapy group did have less mortality than the percutaneous patients, when we did our follow-up at 30 months, we did find that all the patients that were in class 4 heart failure were the ones who had kind of undergone medical therapy and not more aggressive intervention. So it could be that they were just inoperable and we didn't feel like their anatomy allowed for a percutaneous approach. So it is kind of like a complex patient population that we're looking at. So even though they survived, I don't know that they necessarily did better in the long term per se.
Yeah, I mean, again, I think there's a significant selection bias on this, 2-center series, right? And we really have to do a multi-center registry, look at all comers patients in the preferred heart clinic to yours and Myra's and others, to really capture all these patients in a bucket and then see how we decide on these patients and follow them at least a few years to see what happened to them. I'm sure at that time when we did these percutaneous cases, they were kind of almost salvage cases, right? They really want to push for it, and we didn't feel that we could turn them down, and we feel that they might benefit, and then we learn from it, unfortunately, in the hard way. And of course, the ones that have remained in medical therapy may have self-selected themselves, as we the natural history. Some of them might have done okay. In fact, actually, one of our first percutaneous patients, we turned them down initially, and she waited a year. So she was doing fine, and she presented herself with acute heart failure at 1 year. And then by that time, I think Myra's paper's already come out, and we're learning a little bit more about it. So they said, well, let's try it. And then we were successful, and she did quite well. But ultimately, we've been quite conservative addressing these patients because we just don't know, if they'll do okay, just maintaining the current course. And we've seen some patients that follow up just to have a telephone visit, and they said, oh, they're still okay. Nothing has really changed.
So Gilbert, I just want to clarify about the mitral too. Thank you for mentioning that. First of all, it's enrolling very fast, by the way. These patients are coming from a lot of places. But I just wanted to clarify that we're not randomizing because the FDA did not ask us to randomize, and there's no, we just did not know if it was ethical to randomize. We just don't have data. There's a lot of debate about that. What is the right thing to do? And many of us think that yes, randomized data is very helpful, but for some of these patients are very symptomatic. So to make a long story short, it's not randomized. We do have the medical treatment arm for patients who do not have favorable anatomy for transeptal valve MAC and who don't have any treatment options or who prefer not to be intervened on. So patients' preference is taken in consideration, or if they have any other exclusion criteria, for example, severe RV dysfunction, when we think it's already too late. There would be some patient selection bias, I suppose, but hopefully we'll get some information because we will have also the MAC score, I think, and we do have some preliminary data on this, that the MAC score can correlate perhaps with outcomes, because as you move up on the number of the score, it just speaks for more severity of the condition and more chronicity. So I think there is a correlation of the MAC score with higher mortality. The higher the MAC score, the higher mortality of these patients. So at least we were able to compare and hopefully match some of these patients in the MAC treatment arm. Well, actually, we don't call it control arm anymore. It's a natural history of disease registry. Hopefully, we can match some of those patients with the treatment arm and then provide some insights. But I just wanted to make sure that the audience does not have the impression that is randomized, because I cannot claim that credit because it's not randomized. But at least it's the only trial that has that has a medical treatment arm. The other pivotal trials like Summit and Apollo, they do have a MAC arm, but not a medical treatment comparison. So I hope that they add one, and maybe we can pull data from all these trials to increase the number, because we will only have 100 if we get enough of those patients entered in the trial. The speed of enrollment is much faster, or has been much faster in the treatment arm versus the medical treatment arm. Intervention arm versus the medical treatment arm. So I worry that the intervention arm is going to fill the spots a lot sooner, and we may not have enough in the medical treatment arm. So hopefully, the audience can put some pressure on the other trials to add a medical treatment arm.
Yeah. Thank you, Myra. Sorry, I misspoke. Yeah, that's right. It is a medical control arm, and I think it's important.
And I'm sorry, no, it's not your fault. It might be my fault for not emphasizing.
I distinctly remembered, and I think it's very important. It's very important, as you mentioned, to look at these patients' natural history who do not have the anatomic suitability, as you mentioned, even with adjunctive techniques that you now have at disposal for your trial. To look at how they do. And I think maybe one reason why the enrollment and the non-medical side is that maybe you guys are learning so much about how to intervene on these patients safely that not that many patients are left to actually not able to do this. And of course, Kendra and others have shown in the literature about some of the recent Lampoon results that they were almost, even though the self-selected group, the outcomes were quite excellent. And also to your point about the MAC score, we've seen actually a couple of patients, we rescan the CT at like a couple of years afterwards to see if they might become anatomically suitable from a lower MAC score to a higher MAC score. And sure enough, actually, some of these patients, their MAC does progress, as you have as you've spoken about. So some of these patients may become actually anatomically eligible that otherwise might have not been so before. And it'll be interesting to see, to this point, whether that might correlate with outcomes.
Thank you. Just one more word about that, because I take responsibility for the confusion, Gilbert. I have seen on Twitter also comments, so I think it might be that I was not clear enough when I have presented that there are two arms. I think I should have emphasized that more, because I have noticed confusion also on Twitter from other people who think that it's a randomized arm, and it would be nice, but I cannot take credit for that. I just wanted to use this platform to clarify that, and I apologize if I wasn't clear enough when I initially, have announced that or presented that. Thank you.
Thank you. Thank you all.
I have a question for Kendra, if I can. I see there are 2 minutes left. On the Emory angle, can you tell us, do you always calculate that? That's the first question. Second, what is the proportion of patients in which you end up deciding, when you apply the Emory angle, in which you end up deciding that an apical rail is needed? Mm-hmm. That's the second question. And the third question has to do more with the proportion of your algorithm, like how many of your patients go for lampoon first, or you decide to offer lampoon first versus alcohol ablation. Like, how do you work? How do you do that? Do you do lampoon first as the first choice and add alcohol if needed as a rescue? Or what's your algorithm there?
Yeah, so every patient is assessed for the neo-LVOT and the Emory angle, regardless. It's just part of our pre-operative CT analysis. Any patient who has a canting angle more than 15 degrees, we would then discuss in heart team for an apical rail. And those patients are more likely than not going to get that procedure, okay? Or that adjunct, I should say, during their procedure. The third question, alcohol septal ablation versus lampoon. So just for the audience, because we haven't touched on this, lampoon is a way to use electrified wire, so electrical surgery techniques, in order to split the middle of the anterior leaflet to open up the LVOT. So you can do it multiple ways. You can either perforate the leaflet at the level of the annulus and pull in order to get the leaflet to split, or if you come through the aortic valve and then through your transseptal puncture, you can come this way and come backwards, but you need a backstop. In order to go tip to base, you need a backstop. So that works in valve and ring, and that works in valve and MAC, as long as that backstop is there. Otherwise, you have to be careful with the annulus. So that's lampoon, electrosurgery to split the anterior leaflet. With my two partners, Bacillus and Adam, we are electric surgery if we can. So if the patient has any risk of LVOT obstruction, that's going to be our first choice. We do use alcohol septal ablation and also radio frequency, rarely, but they've described that technique as well. But lampoon, they're so facile with it and such proponents of the added benefit that we really, if there's any concern, just like a surgeon would resect that segment, they're going to split the leaflet. There was a second question. What did I miss, Myra?
No, just the proportion. It wasn't clear to me, like what proportion of patients end up having or requiring a transapical rail after the Emory.
Yeah. So, I mean, those would only be patients that would be in a valve and MAC or valve and ring where you're worried about coaxiality. I don't actually have the data on what proportion. I would say less than 50% over our whole series. Certainly we published a small series, and it definitely increases our coaxiality, increases our PVL and our results, or decreases our PVL and increases our results. But it's something that every patient is assessed for. But if you look at all valve and MAC, it's a smaller proportion that actually need it. Or excuse me, all valve and mitrals, it's a smaller proportion. because your valve and valves are probably not going to need it. So now you're left with valve and rings and valve and mags.
Thank you.
Thank you, Dr. Grubb. That was actually, I think we've covered a few questions that we were having regarding the Lamphone technique, and also based on the results of Dr. Alexis, there was a question of TMVR versus medical therapy, and Dr. Guerrero also spoke on that. We have a comment from Dr. Maizano, who is in the audience. He says, very complex and challenging situation. Surgery is not always higher risk than transcatheter alternatives. Tendyne is a great solution, but many patients do not apply. Then we remain with hybrid solutions and rarely with transeptal. But do not forget that you can implant valves surgically using some tricks. I use leaflet rather than annular sutures and pericardial skirt to control paravalvular leak. Dr. Tang, what are your thoughts on this comment? And since we're also nearing the end of our live talk, what are your thoughts on transcatheter therapy and how cardiac surgeons can train in this? We were reading your paper about the train which has left. What do you think is the role of new trainees that are aspiring to join structure of heart to be more actively involved in this?
Well, thank you for the comment, and I'm sure Kendra can mention. Yes, of course, Francesco is a good friend and mentor of ours. Yes, you can definitely implant the valves using some additional trick, because remember, this is all new. 10 years ago, none of us would be talking about this method of treating these patients. So how do people do it? Well, they can do it aggressively by resecting the MAC and reconstructing it, but that can add a lot of complexity to the operation. So some people use the atrium as your friend to actually anchor the suture, end up implanting the surgical valve almost atrially, rather than actually across the annulus. And again, as I mentioned before, it really depends on whether the leaflets themselves are calcified. If they are not, you can almost always sneak a couple of surgical sutures to implant a conventional surgical valve. And at least in our reference center, mitral center, that's been our go-to approach. If it's a type 1 and obviously cannot anchor a balloon expandable valve and the dedicated device are not an option for this patient, then we would do a conventional surgical valve replacement, carefully avoiding AV groove disruption, and that can be done safely as well, obviously in highly experienced center. To your point about getting surgeons more involved, I think all of us been blessed and lucky, and Kendra and Myra have been in centers that foster a really true heart team approach with active surgeon involvement. And Sophia has been a beneficiary of that. I hope she rotated with us for quite some time. I think the key for surgeons is to get involved and engage in the imaging, get engaged in going to the cases. Participating is not just valve and MAC cases, because those are rare, like mitral clip cases, any transcatheter mitral cases. You need to be involved and you need to speak the language of the team to be able to understand what we're talking about. What is Lamphone? What is the Emery angle? What is this annular dimensions or neo LVOT? Those are kind of new languages that you need to learn, and you need to learn about echo and CT to be able to actively participate. If you just going to be talking about patient surgical risk and not really get involved in the patient's surgical care, you're not going to be involved in the care of the patient. And I don't think it's fair for the patient either, for you to try to be involved without knowing the patient's detailed history, anatomy, and the plan. And I think you have to, and the other benefit of having a surgeon involved is that you now offer all the different options to the patient, not just percutaneous or medical therapy. You also, as we mentioned at our center at least, also have an equipoise of offering surgery about a maybe high risk, but clearly still an operable candidate to see what the patient would benefit most.
Thank you, Dr. Tang. Dr. Guerrero, what are your thoughts on this, and how can cardiac surgeons and interventional cardiologists remain relevant in both surgery and transcatheter therapies? Where do we find that balance, and what is the optimal way to approach this?
You read my mind. I was thinking, oh my God, I'm at the wrong meeting. I'm not a surgeon, and being an interventional cardiologist, I'm biased always towards the less invasive procedure. And I think there will be patients who will need different types of treatment. So in other words, there's not one solution that fits all. But in my world, or in my opinion, if a patient has favorable anatomy for a transeptal transvenous procedure that is much less invasive and allows them to go home the following day or soon after that, I think that should be utilized. And then if that's not an option, if once the new mitral transcatheter devices are refined, as Dr. Grab already mentioned, they will be refined, I'm sure. That may be a second choice. And for patients who do not have any of those two options, and who perhaps are younger and lower surgical risk in general, who can tolerate a transatrial approach, then we have that option for them. But to be honest, if you ask me the question as an interventional cardiologist, I would vote for transeptal. I think the Mitral 2 trial will really help a lot provide data on that. I don't know if I'm allowed to give you a preview of our results of what we have so far, but all I can say is enrolling fast. We have had treated already 11 patients. I cannot tell you that we have 100% technical success, because I cannot tell you that, and for that reason, I'm not going to tell you that we have 100% technical success. But if you read between the lines, I'm trying to say that I have been impressed, at the results that we're getting. It has to be highly selected patient population with implementation of any of the risk reduction strategies for LVOT obstruction. But if you do that, I think we can achieve 100% technical success, or a very high, let's say, a very high technical success in these patients. Long term, I don't know what this will mean, but at least we have made a lot of progress at going to the table, to the cath lab, and say with confidence, I think we have a likelihood of technical success that is going to be for sure more than 85%, but near, 100%.
Yeah, Myra, I think you brought up an excellent point. I think, any kind of complex surgeries in the surgical world, in terms of structural heart disease, they need to be done with a dedicated heart team or expert in this field, right? Like yourself and like Kendra and others. You cannot just try to do this, in your own center if you have not done one and you're going to cause harm to the patient. I think that's a very important message to the audience. And it's okay to, we're all learning, and you have these advanced adjunctive techniques that are not that simple to start. There is a learning curve with this. And so I think your trial will give us a lot of insight on expert centers performing these procedures and how they do. And to your point, it will likely be fantastic. But I think I would caution people out there to, try this at home, because it's a very complex procedure. And remember, as Gianluca mentioned, these are not devices dedicated for the mitral position. I think, let us repeat this again. So we are trying to treat these patients with a non-dedicated device. The FDA did not approve the balloon expandable valve for the mitral position, other than the valve-in-valve only. So I think we need to tell that to the audience, that this will take some time to master, and hopefully there'll be new dedicated device out there. And also importantly, to Myra and Kendra's point, that we need the techniques to be more reproducible and easier for people who are non-experts out there to be able to do it safely and efficiently, because you don't want to have to struggle for 5 hours in the lab to try to do these adjunctive techniques and put the patient at risk of general anesthesia or hemodynamic perturbation. So I think it's important to make that point to the audience.
Dr. Grubb, what are your thoughts on how to balance training in structural heart, and what, as being a resident myself, Dr. Alexis is also a trainee, there's always that question of balancing time, the amount of time you dedicate to structural heart training, which could mean time out of the OR, doing open procedures. What is your fine line and strategy for us trainees to approach this very, very vast field?
Yeah.
So let me repeat the question to make sure I understand correctly. I think I lost the fragments of your question. Are you asking, if the surgical training should include transcatheter training? Was that the question?
Correct. He was asking how to balancing it. It's always difficult for a surgical trainee how to balance between open cases and a transcatheter.
Yeah. Well, how to balance, I don't know, but I do know that we're getting into an era where the borderlines between, or the frontiers between one field and another one becomes a little bit blurred when we all kind of need to expand a little bit on what we do. And I mean, definitely, for surgeons, I think you're entering a new area where you need to be trained also in transcatheter techniques. My hope would be that in the future, hopefully not too far from now, the first choice my hope would be that transcatheter options or interventions will be refined so much that can be the first line of therapy for patients. And only when transcatheter option is not an option, then you do surgery. And I'm saying that in a selfish way because when I need therapy, that's what I would like to see the field go into. So that's my hope. And I think there's a good chance that would happen. So anticipating that, I would want to be prepared for that new era. So I think you need to focus on that. One more frontier that we need to expand or get into, all of us. We don't, is imaging, cardiac imaging, CT analysis. I mean, you already showed, how the CT is so important. So I think we also need to get some training, incorporate training on CT for any of our fellowships, cardiology or cardiac surgery, or structural interventional fellowship in the cardiac surgery fellowship as well. So we need to expand our horizons. It's not so confined as it used to before. The proportion, I don't know how to keep it balanced, but
yeah.
And Myra, I have tremendous respect for that strategy. My only concern of percutaneous first is what we've seen in TAVR right now is that our device development has outpaced our data. So we know in 10 years, from 2010 to 2019, TAVR went from high risk or inoperable to low risk patients. We have no idea how long these valves last. So Gilbert's work in explant TAVR will help us understand even how to take these valves out and what happens. This is going to be true in all of the percutaneous technologies that don't have a durability answer today. So although percutaneous first may be the right choice, we don't actually know that right now. So getting back to the surgical piece, I think it's absolutely essential that all surgical residents end up with some basic training in transcatheter therapies. So one, they can speak the language. Two, they can have equipoise when they discuss the TAVR versus SAVR, mitral clip versus, or TEER versus surgical repair, or when these transcatheter mitral replacement technologies are ready for prime time, they can actually understand the difference. And right now, we have a whole bunch of devices that once they fail, we still don't know what to do with those. So I think the surgeons would benefit from advanced skills in structural heart to the point where, I spent a year at Columbia doing interventional cardiology and transcatheter therapies. So no different than the aortic surgery doing a super fellowship, the transplant surgeon spending a year doing nothing but transplant. I think if you want to be in this space and you want to be at the level that Gilbert's at, or Isaac, who wasn't able to join us today, that you're going to have to spend the extra time to get the skills. If you want to be a surgeon in this space, it's a subspecialty that not only is the first valve, it's the lifetime management of these patients. And what do you do for the second valve? What do you do when there are no more options for valve and valve and valve? Using pericardial tissue as your leaflet technology, there is a finite amount of time these valves are going to last. We do not know durability yet.
No, I agree. That's why I said it's my hope. I'm not saying we're there yet, and it's just we're years, from that. It's just my hope.
Sure. It's very important hope, but I echoes what Kendra was saying, and I think that even in the world of TAVI and surgical AVR, we have seen a shifting of the curve too early and too strongly towards one direction. And I think that for the good caring of patients, we need to make sure that more than percutaneous first comes heart valve or heart team discussion first, where people with different skills but with the knowledge in one specific topic, that can be aortic valve or mitral valve, comes together to define a tailored approach for that specific patients with that specific anatomy, with that specific age or characteristic, what is the best treatment for that patient. And you should be able to offer all of the portfolio, from a ROS procedure to a surgical AVR to a complex TAVR in different type of scenario. While this world of cardiovascular disease enlarge immensely with skills, technologies, images, as Mayra was saying, all of us needs to find a niche where it's your field of action. And I totally agree with Kendra. Transcatheter is becoming a field of action in which surgeons needs to have their own role and their own space. And I think all of you have proven that. Gilbert, you, Kendra, Isa, and a lot of other persons. So it's important to maintain this type of elements. Thomas Salerno, you are the editor-in-chief of the journal, and your wise words as a senior person are always welcoming at the end of this talk. Please leave us with some taking home message from your wisdom.
I want to thank you all for participating in this important session. I think this kind of session underscored the importance of your article that led to this discussion, adding a new dimension to this important topic. I think that one of the important issues that was brought up is the issue of future generation of cardiac surgeon and cardiology working together. One of the problems with cardiac surgeons, in my view, is that we want to spend time in the operating room. It's not that these procedures require pre-op, post-op, follow-up of the patient. It's not just going to the operating room and helping deploy the valve. It requires the dimension of following these patients. I think another important thing I always say to cardiac surgeons, if you want to hear about the field of cardiac surgery, you should attend a cardiology meeting, because in that meeting, you realize the dimension of where this field is going. I mean, it's becoming very appealing. The other thing is COVID. One of the advantages of COVID for cardiology is we shifted all those patients to interventional procedures. And once you go in that direction, you become more and more liberal in using this technology. But I'm very grateful to all of you for the discussions we had. I think the audience will have enjoyed very much an in-depth look of a field that's become super specialized. And I think, as Kendra said, is that those of us who are interested in pursuing some of the discussions we occurred here will probably have to have a fellowship like in heart failure, or even now coronary artery surgery by Pushka is become a subspecialty. But I'm very grateful for you to taking the time and coming. I hope you consider submitting and discussing with us in the journal. And thank you very much, Gianluca and Ivans, for organizing this session.
Thank you.
Thank you so much. Thank you so much, Mayra. Thank you, Kendra. Thank you, Gilbert, for taking the time. All of you. Sophia, thank you for rounding at 4 o'clock in the morning and making the time to be here. I know that is pretty admirable from you. And always important to have this type of discussion. This is our format, 1 hour, very friendly and formal conversation. Looking forward for the next Journal of Cardiac Surgery live talk next month. Subscribe to our YouTube channel, or keep us to keep yourself in the loop of when we're organizing, and drink a coffee and learn something about a new topic of cardiac surgery. That's the field, the mojo of these talks. Thank you again, everyone, and see you next month.
Thank
Bye.
you.
Thank you very much.